We will now hear about the childhood leukemia paradigm from Professor Vaskar Saha. Professor Saha is an India Alliance Margdarshi Fellow and is also the director of Tata Translational Cancer Research Center, Kolkata, and a professor of pediatric oncology at University of Manchester, UK. He leads biomarker research and clinical trials in childhood leukemia.
So I think some of us worked out yesterday that this screen is useless. Okay, so I know some of you can, but the majority of people can see this screen. It's actually very difficult to manipulate both. So I'm going to do exactly what Ashok did, which is primarily use this screen. So if I wander out and block this because the projector is here, I apologize. Okay. Sorry, can we put that back on show again? Right, so the title is actually some of the objectives that were embedded in this fellowship that I began in early 2014. And that time it was at what was then a very newly opened hospital. And at the time I started, I shared the responsibility of children with cancer with one other consultant. I had no research facilities, I had no staff, and the only equipment I came with was the laptop that I had brought with me from UK. And so what I'd like to share with you today is some vignettes from the journey of the last 4.5 years. So coming back to the topic itself, what you can see here is box and whisker plots, which illustrate the differences or disparities in outcome of cancer in 3 different cancers. The red is in North America, yellow is in Asia, and I put a black bar here which shows you the differences in median. If you look down there, you can see some differences at minimum 15 to 20% in these common cancers. And if you look at, and these are from 2 recent publications, so if you look at the differences here in India and the West in these common cancers, with the exception of cervix, you can see the difference is actually 25%, particularly in acute lymphoblastic leukemia, where if you look at the outcomes of 90%, which is almost cure, to 65% in India. Now, one of the contributors to this disparities in outcomes in India is, of course, the cost of therapy. And centers like ours in Kolkata, through generous grants from both the government and non-governmental organizations, are able to heavily subsidize inpatient therapy. But patients still pay a considerable amount of money for travel and subsistence. And if you look at over here, this white bar over here is the outpatient costs. This is the scale 150 to 200% of patients coming from rural areas who are coming to hospital. And this is so the cost of out-of-pocket costs can be substantially more than the cost of therapy. The further the patient travels, the more the expenses go, and this for a low middle income family can push them into poverty for a generation. So that's a different problem. Now coming back to acute lymphoblastic leukemia, so this is the outcomes of 3 different Western and 1 Asian study group in this decade. This is the survival over here, and you can see the survivals are all in the mid-80s. And this is actually the results of incremental improvements in outcome using the same drugs for the last 5 decades by first intensifying combination chemotherapy in all patients. Problem lights? Too bright, no? Yeah, if you can bring the brights on, yeah, if possible. So if what we subsequently discovered is that there are groups of patients identified by clinical criteria or cytogenetics who are at higher risk for relapse, intensify therapy for them further. And in this modern era, we now have molecular tools that can detect residual disease after treatment. And in patients who have less than optimal response to therapy, we intensify therapy further. Okay, so this risk stratified therapy. So how have we done so far in India? So this is the outcomes of patients in India. You can see the outcomes here at the bottom, which is about 60% to 65%, which is 20 to 25% different over here. And actually, this is the earlier results. So results have not really improved in the last 3 decades. And if you look at the reasons for this, so this is PGI Chandigarh has decreased the relapse rate from 27 to 15%, but overall this treatment-related mortality still remains the same. So why are patients dying? So there are some reasons for this. One is all these groups use risk stratified therapy using the criteria we showed you here, and this risk stratification limits or decreases the intensity of therapy for patients at low risk of relapse. Centers here in India have not been using this kind of therapy, and they are then forced to treat all patients with moderate to high intensity therapy, which relates to this treatment deaths. Furthermore, if you look at these groups, these are all multi-center studies which have large cohorts, okay, which allows adaptation to events within the trial itself. Single centers which have smaller cohorts cannot adapt to this, okay, and they will only be wiser after the event. But there's one more factor that I would like to bring out to you, and that is that if you look at this, you can see there's a long recruitment time, 7 to 10 years, and the gestation times to publication. So the average time from recruitment to publication is 10 to 15 years before the data actually comes out, okay. Many things happen during that time. Many changes happen in the clinical trial. And that's because these groups all work together. Not only these groups work together internally, they also work across. So the Germans know what the Americans are doing, and the British know what everybody else is doing. So at the end, when the publication actually comes out, it only reflects a small piece of information. So what we really need here is open access to ongoing studies. Open access to publications does not help. Okay? So what we did to try to address some of these problems was we brought together all the major pediatric oncology centers in the country, and they're here. This is where all the patients go to. And prior to the study of the fellowship, or start of the fellowship, we organized a common protocol and agreed to this. We played to the strengths of the centers by helping each center, one center as a nodal center to standardize the MRD, cytogenetics, and the clinical trials. And we also were very lucky to get the generous offer from the international group, where waived the cost of registration and participation in closed workshops, but our participants still had to pay the cost of travel, which they had to pay from their own pockets. But nevertheless, what happened at least was equity. Patients no longer a lottery of where they were going. All centers treated uniformly. It also allowed patients to opt to stay at their local center, but more importantly, for patients who actually went to a different center, say from Kolkata to Bombay, they could come back at any stage of their treatment and just carry on from where they had left off to. So just to show you what the strategy is then, we divide the patients to standard, intermediate, and high-risk group based on cytogenetics and the clinical characteristics. You can see for the first 5 weeks, the low-risk patients get less intensive treatment, the high-risk get more intensive treatment. At the end of 5 weeks, we do a bone marrow and we measure the minimal residual disease. The children who have lower disease level less than 1 in 10,000 carry on with less intensive therapy. If they have higher disease than 1 in 10,000, they join the high-risk group. And that decreases the treatment intensity for this group of patients. But in spite of all this is the first sort of 6 months of treatment. You can see that the majority or the longest duration of treatment is this 2-year treatment of maintenance. So what happens during maintenance? So during maintenance, all children receive daily dose of 6-mercaptopurine. Now, thiopurines have a wide pharmacokinetic variation, and this requires constant adjustment of dose. And we do this by monitoring the side effect of the drug, and that is neutropenia. We try to maintain the child's neutrophil count between 1,500 and 750, and this is done by fortnightly blood counts, sometimes weekly. And to avail of this, there are families who will stay next to the local hospital for 2 years, okay? And I realized that even families who are just coming to my clinic, that majority of my families were spending an overnight trip coming, an overnight trip going for a 10-minute visit to the outpatient clinic, okay? So what we began to do is we began these patient health records first, which actually they put the count in, they put the dose in, they scan it. There are kiosks everywhere, even in small rural areas. They can email it to us, and we email back the dose to them, okay? And we monitor this, and that way actually we're capturing the data as well. We're now beginning to develop this as an app that they can do and use. But one of the things we realized is that clinicians who are doing this are very quick in decreasing the dose or stopping the dose in somebody whose counts are dropping. But they are not escalating the dose in children who are not getting the optimal dose. So we decided to look at this. And the way we did this was we took 46 patients in my clinic who had completed 2 years of therapy. And this shows you each dot is the average mean weighted neutrophil count for the entire 2-year period. So it's about 6,500 observations in all, okay? What you can see over here, this is the target. The target neutrophil count should be between these 2 lines. And you can see some of them, but not all. And this is the mean weighted dose. And what you can't see here because the light is too bright is that there's a yellow box here, and actually this is where most of the patients should lie, but they're not. So we were very good at stopping treatment in patients whose counts are, but we were not escalating therapy. And that can actually change outcomes by 10% if you don't optimize the therapy. So we've now got a system by which these counts are automated in the clinic because the clinic is very busy, and this comes into an app which is on the doctor's phone, and this tells a doctor how much to prescribe, okay, based on the data that they've got. Because the tablets are 50 and 25, and that's all we can get, this produces a printout for the patient, so the patient has a visual, prescription to see what is happening. And for patients who actually have an Android phone, which is a smartphone, we can put this app onto them, which gives you a daily alarm saying this is how much you need to take, this is what you take. And when they press the button, we get a record that they've actually taken their medications, and that's another study. Now, how have we done so far with this study? So this shows you the treatment-related mortality historically. We ran a 3.5-year pre-trial study and now a randomized study. And you can see as the groups have got more familiar with the protocol, mortality is now as per sort of close to Western standards. Relapse rates have decreased as well. This 1% is too early because there's only first-year data. Outcome data then, so this is the whole cohort now. This is 3-year study, 3-year survival. We need another couple of years before we know where this stabilizes, but still this is much higher than has been achieved before. And the whole focus was in getting the best outcomes in the standard risk by delivering least amount of therapy. There was a lot of nervousness among the Indian investigators, worrying that there will be a high relapse rate, but we are approaching 90% or over 90% outcomes in the standard risk group by giving them the least intensive therapy. So far, so good. But we have a couple of problems. One is if you look at this cytogenetic subgroup, this intermediate subgroup, which is actually a diagnosis of exclusion, what you find is this about half the population, which shouldn't be more than 40%. So we're seeing more intermediate risk groups, but this also may be because in the earlier days of the study, cytogenetics was not standardized and the centers were not able to identify the good risk patients. But if so, then we shouldn't see this 15% difference in outcomes between the good risk and high risk. It should be higher. So either we're seeing more, or we have a more high risk category in this intermediate risk group. And the second was in this MRD subgroup. So high MRD should be seen in 40%. We're seeing it only in 20 to 25%, which suggests that the tests that we have standardized are actually not as sensitive as we thought they were. So we began to start looking at this more closely in the Kolkata cohort in my center, because we were being investigating them more closely. So if you look at the cytogenetic distribution, this is the UK distribution. This blue and the yellow are the high upper diploid and ETV6 rungs 1. These are the patients who have 90% survival, and these are low risk. And you can see clearly that our cohort is smaller, particularly in the ETV6 rungs 1, probably not as smaller as was indicated by the cohort study, but high risk is about the same. The intermediate risk group is a little bit bigger. But what stands out here, if you notice, is that we see a larger proportion of patients with high hyperdiploid compared to the West. Now, high hyperdiploid by itself is a heterogeneous condition. All it says is that it's a condition where the nodal number of chromosomes, there's a whole gains in chromosomes in era mitosis, which is 51 to 67 chromosomes, and these are the commonest chromosomes that are duplicated. So we looked at this with a high-density SNP array. So the patients here are in rows, and the copy numbers are in columns. I'm afraid the light is not allowing you to see them very clearly, but what you can see here marked in the asterisks is that we see the same chromosomal duplications. This is also showing you a different kind of loss of heterozygosity from what Ashok showed you, which is how the chromosomes are duplicated, uniparental isodisomy. So the chromosomes that are coming from one parent, and that's being duplicated, and the other parent is lost. Okay. Now, in the West, what has been reported is trisomy 11 occurs in 10%. We see this in 25%. But the most striking feature is that in the West, what has been reported is that whole chromosomal uniparental isodisomy is seen in non-random fashion in 8%, and in chromosome 9, 7, 11, and 12. We are seeing it in 48%, and it's a very random pattern. Okay, we can't really say which chromosome. So the pattern is actually quite different. Okay, if you see, look at chromosome 18. Okay, we see almost all our patients carry duplications of chromosome 18. This is associated with EFS of 90% in Western studies, but actually a third of our relapses in our cohort are coming from this high hyperdiploid type. So all indications is that, at least at the epigenetic level, we are seeing a different high hyperdiploid cohort. I mean, certainly in the treatment response pattern, we are seeing a different high hyperdiploid cohort. So we've been also mapping this at the somatic mutation level. And again, you can't really see this, but these are the genes which are mutated in our targeted exomic sequencing profile. In red are all the genes that have been identified in this group of high hyperdiploids. So we see them all. But the frequency of genes that have not been detected, and these are much higher in our cohort. which does suggest that at least at the gene expression level, we are going to see a different expression in these high hyperdiploid cohort. Gene expression will correlate to treatment outcomes, and that's what we're currently investigating. So moving on from that was the question of MRD, right? So the flow cytometry-based MRD is used throughout the centers because it's cheap, it's rapid, everybody's got a flow cytometer. We set up genomic-based PCR, which is used as a research tool, but we also use it diagnostically for relapse patients, because relapse patients who have high MRD after the first block of therapy become eligible for transplant, and so therefore an expensive test is worth the cost. So I just want to show you this one. This is the end MRD levels at the end of first block of therapy. This is flow cytometry. Blue is the ones who are below 10 to the power minus 4. So in this, you would say that 80% of patients are not eligible for transplant and may be cured by chemotherapy. If you use the genomic PCR, this drops to 40%. Okay? So clearly, these patients are a much higher risk of relapse and are not being picked up by flow cytometry. If you look over here now, PCR is actually being replaced by high throughput sequencing, and this red cohort is a group of patients retrospectively analyzed by the American Children's Oncology Group using an Illumina platform, where they identify patients who are positive by high throughput sequencing but negative by flow cytometry, who have a different outcome to compare to patients who are negative by both techniques or positive by both techniques. Now, the Illumina platform is a little more complex and expensive, and we've started exploring about whether we can use this nanopore technology to actually do this, because one of the big problems we do have is that this technology of MRD and cytogenetics is not available at most centers. Flow cytometry uses fresh cells, and this is difficult to transport. A genomic solution to MRD and genetics will allow us to risk stratify patients across the country, across all centers. Now, the question about MRD that is there is that why do you have a small proportion of cells that are still surviving? And the obvious suggestion to this is that you have subclones which have different genetics, okay, which have subclonal mutations acquired after the first initiation event. Okay. Now, the most common subclonal events that you see are deletions or mutations of the developmental genes, cell cycle genes, or signaling genes, and they're listed here. I'd like to just draw your attention to this one, which is IKZF1 and deletions. And that's the one that has been prognostic across many different series. Not, doesn't matter how you treat them. Different groups across the world have reported this is prognostic. And you can see this in the group recent report by the Italian and German group. And this is a group of patients who are defined as Icarus plus. So they have an Icarus deletion plus a deletion of any of these other genes. And these are the ones who have the highest relapse rates. But even there, you can see that there are patients here who are MRD negative, and they actually have decent outcomes. So there are some other factors that are going on here. So you investigated this now in a relapse cohort, because that's where you expect these clones to now get enriched, and you should be able to now pinpoint now which are the cells, which are the mutations and cytogenetic changes that are coming out. So you can see this is low risk cytogenetics, intermediate and high. This is the green is low MRD, high MRD. And as you'd expect that from going from low to high, the proportion of MRD is increasing. So this is 50%, it's about 65%, and here's almost 80% of patients are high MRD. If you look at the subgenetic changes, which is the Icarus, PAX5, etc., what you can see here is that in the MRD positive cohort is now getting enriched with deletions of Icarus, PAX5, NR3C1, CDKN2AB, and mutations of NRAS, and not the others. Now, what would be the potential, relevance of that, and I'll come to that. The other thing we did also was to look at the outcome of these relapse patients as they went through, and saw what emerged in the second relapse. And you can see that MRD predicts what happens to these patients very clearly. But surprisingly, none of the other mutations came out. The only thing that came out was mutations in P53. Okay, so patients who had mutations in P53 were the ones who did poorly, and this is either mutations or deletions. And actually, P53 mutations we hardly pick up at all at diagnosis. It's only coming at relapse. It's less than 2% and 13 to 15% at relapse. So that suggests there's an enrichment of a lower-level P53 clone that is actually coming out, and that is drug-resistant. Now, to put all this together then, what is the commonality between all these genes? So there's a recent paper showing, and this is some of the work we've also been doing, that leukemia induces a glucose resistant or insulin resistant state, okay, which allows a lot more of glucose to be available to leukemic cells. And actually, even though these are transcription factors, the way they regulate this Icarus 5, NR3C1, PAX5 work together to actually downregulate glucose metabolism in a cell. This allows the B cell to differentiate and stop proliferating. If these are deleted, the B cell continues to proliferate, doesn't differentiate, and enters a state of drug resistance. Okay, so this is a paper by a group in California. And if you have deletions in this cell cycle genes as well, you get proliferation. And work done in our lab and other people's labs also suggests that P53, you know, regulates the cell cycle, but also regulates glucose metabolism, and probably in very similar ways that this does, which suggests that actually targeting metabolism rather than targeting mutations might, so in many ways, in a parallel to Ashok's story as well about the aldehyde. So coming back to where we are now about equity. So we said that we've actually shown that we can deliver cheap, low-risk therapy to a large group of patients using modern technology, but it's actually only affecting 10% of patients. The majority of centers are using our protocols but cannot do the risk stratification. But we've shown also that genomic-based technology can actually do all of this and actually can continue to refine this. So the idea we've got is that if you have centralized laboratories where you send your genome, a piece of DNA, rather than the patient, you can actually make a diagnosis, you can stratify the patients, you can keep the patients where they are. We've developed clinical trial management systems that are actually helping the centers decide how to treat their patients, and including patients taking charge. So the patient stays there. And through this process, you can identify high-risk patients who actually need to travel or only need to come for blocks of therapy. Okay? And that's the proposal we have for acute lymphoblastic leukemia, which we think would probably work for any cancer in this country. So what we've shown you so far is that the approach that we took up, that if you work together, you develop network, and you brought in technology, you could actually make things cheaper for patients, because one of the arguments always is technology is expensive, but actually the cost of the technology is trivial compared to the cost of therapy. If you develop a network system like this, we can find solutions that can be used for all patients. But more importantly, I think from the laboratory, we're now finding that there are possible alternative methods by which you can target these leukemic cells, either to make cheaper therapy by repositioning or repurposing drugs that are already existing, metformin, for example, which might work in glucose therapy. And that can offer much better options to our patients where cost of therapy is escalating rapidly. And so finally, this is where we are now. So this is where the hospital was when we started. This is a new wing that has opened. The pediatric patients have one entire floor to themselves. We have now 6 consultants instead of 2. It's 50 beds, one of the largest units in the country. And behind that, now we have dedicated research facilities. And now to get to this journey that we have come through hasn't been an easy one. And I have to thank many people, more than fit on the slide, both at my center, in India, and elsewhere, but primarily from people from outside, my colleagues from abroad, many of them who have come and spent time at their own costs, paid their own fares to come and teach and train and help us through this process and continue to do so. But I'd also like to thank Tata Consultancy Services, who not only helped us get this laboratory started, but have been integral to our development of the knowledge pipelines, both for the clinical side and for the genomic sides. And I'd like to thank India Alliance, not just for the funding, but also for the fact that the flexibility with the funding. But more importantly, it's been such a great pleasure. From the start of the application, under the lawyer, clear dictators, what was expected from the Indian Alliance led to a successful application. The current CEO has always been extremely responsive to any queries. I can send them the query at 8 o'clock at night and I get a response back. And to the nodal officers who have always worked out saying that, okay, we got a problem, but you leave it with us, we'll find a solution. Okay? For 25 years or more than that, a quarter century of working with different grant committees, this is the best one I've ever worked with. Okay? So what I would like to say today is an old Indian phrase. Okay? 10th birthday, 100 saal jiyo, which is, may you live for 100 years. Okay? And I'll tell you why. We researchers in India need you. Okay? More than you actually think you realize. No, okay? So all the best, and thank you very much. I haven't woken up for breakfast yet.
Interesting talk. Yeah. Hi.
Right.
Interesting talk. I just have I treaded a little bit away from what you were talking about, and I realized that drug resistance seems to be a problem even with cancer therapy. When you consider relapse, is that in any way, have you considered relating it to development of drug resistance in that being a cause for relapse?
Yeah, it's probably too big a topic to talk about. Yeah, it's drug resistance. So basically, you define drug resistance very simply that you target a cell and the cell survives, right? Okay. Now the question is why the drug resistance, and I think Ashok alluded to that in I think his first or second slide, which he said it's the genetic constitution of the person, the genetic constitution of the tumor, and the environment. Okay, and certainly, I think that's common to all mechanisms of drug resistance.
So you've covered the deletions and the further mutations that are happening. All that has been covered in that umbrella, basically.
I haven't talked about our work with the microenvironment and how we are dealing with how the microenvironment deals with drug. We have published extensively on that, but 20 minutes is too short a time to fit that into the story. So.
Thank you.
Hello. You mentioned, it's me. You mentioned something very important, that it's not enough having open access to the publications. You need open access to studies. And I think that applies for science in general. And I have two questions. Number one, isn't that achieved, at least in clinical trials, through clinicaltrial.gov registration? That's generally mandated for clinical trials. And secondly, what are the statistical implications when you release a study too early? There's a quality issue. You are affecting the power of future studies. So how should all that be taken into account?
Yeah, I think the simplest explanation to your first question is that no, because you have to be there in the room when people talk about unpublished data and work with each other saying, what does this data mean? So it's a bit like, you read Ashok's excellent paper. None of us are going to be able to do this work by reading his paper without even done any laboratory work at all, okay? So it's not, you have to be there. You have to learn how negative decisions were taken. We're not going down this line. That decision actually might work for you, but not for Germany. And you have to be there in that room. And the second question that you had was about, statistical. Yeah, so statistical implication is we're moving away, and actually, this is my belief, we're moving away from these large-scale randomized control trials, okay, into the N of 1 kind of basket kind of things that are happening in the West. This is much more difficult over here. And in terms, again, by being within the groups that have statisticians that have been working with these problems for decades, okay, I've been struggling here. My statistical support still comes from UK because I've been struggling here to find a statistician who understands the kind of clinical trials we run and what are the issues over there. And Gautam's have been nodding his head because I've been talking to him about it as well. But I think that is surmountable, but the first one is not. No, that's not true. That is not true at all.
But that's where the problem is, because in a sense, your power is based on the final pre-specified analysis.
Correct.
So when you do more frequent analysis, you're reducing the power and you're increasing the, let me finish, okay. You're increasing the chances of false positives. Nothing wrong with it, but that needs to be built into the statistical thinking. And this may be where we have to develop an entire body of Bayesian statistics for dealing with trials.
Yeah, you're preaching to the converted about Bayesian statistics, but we build into because if you look at how we are required to report trials now, we have to actually give the pre-analytical statistical study that's there. In all of this, there's always a question, will you recruit enough patients to the study? So we have interim analysis built into that, which we have to report back to the data monitoring committee, which will say the study is futile, you're never going to recruit, so we close it, okay? So those decisions are built in. As you go into these sub-variables of what happens to the mutations, then you have to use a probability and Bayesian studies to start dissecting out what is happening. And as you said correctly, they have to be built in right from the beginning and not done post-hoc.
One last question from Srilaja.
About polyploidy.
I think I missed it when you said it. So in your hyperdiploid analysis, the loci that turned hyperdiploid included the causative loci for those kinds of leukemia?
As far as we know, the high hyperdiploid is an initiating event, because you can pick this up in Guthrie cards from cord blood in patients who have not yet. In such a study is actually, I don't think
It's
anybody's
hard to
looked at
assign.
exactly all the events that have happened, though I guess modern technology might be able to do that, but we've not looked at that.
Because with chromosome painting, etc., maybe you could tell exactly which ones have turned hyperdiploid.
The high throughput SNP would tell you whether
Yeah.
it's the same thing that you're looking at further downstream. It's a very interesting question. I'm a clinician. I don't really care how it works, how it happens. I want to know if I can shoot it down.
Right.
Thank you very much.